of the ammonia occurs. So this is the new guideline that has been published just around a week back, the ISHEN consensus on the management of encephalopathy, which lays quite a bit of stress on nutrition. It says that there has to be a intervention, and they have been shown to reduce hospital admissions, though there is no definite effect on survival, and larger studies are needed on these. The guideline mentions what has already been talked. The nutritional requirements are not different from the nutritional requirements of cirrhotic patients. The same calories of 35 to 40 kilocalories, with splitting off of the meals, with a late night snack and high amount of protein intake. And what's new in this guideline is that it mentions two things: that the myth that possibly animal protein is poorer than vegetable protein is something they feel needs to be debated and studied further, rather than giving a blanket statement on it. And when we tell the patient that you take 35 kilocalories, it's not sufficient. We have to give them an idea of which protein takes what amount of calories and intake. So normally a dietitian consult is what it's being promoted, that it should include the common food the patient takes, and then the protein and the total calories should be calculated. The guideline also has a very good concept that it says that there should be some personalized and practical dietary counseling. What we normally see in our institutes, when a patient from, say, East India comes to Hyderabad, we give him a diet chart which says you take idli in the morning, you take dosa in the evening, which is not his diet, and he goes in his room and never uses it. It also says that branched-chain amino acid supplement should be considered for prevention of HE recurrence, especially in patients where the protein intake is inadequate. And by telling this, I feel that majority of these patients will have inadequate protein intake, as has been shown by the previous speakers. So my talk, the next of the part, is on something very controversial: branched-chain amino acids in hepatic encephalopathy. So I feel it's an old wine in a new bottle. So why I tell this is that if you see this picture, it's 1893, the Chicago Consensus, where Vivekananda was speaking. It has a striking similarity with branched-chain amino acids. In 2020, when we searched, there are 111 brands of branched-chain amino acids available in the market now, not medical, many of them. So this all started way back in 1893, when this young scientist felt that if we cut the blood supply to the liver, still the person can survive. He did this experiment on 8 dogs, where he ligated the portal vein. His optimism was possibly excessive, because out of these 8, 7 of the dog died. And he concluded his experiment, which was possibly the shortest experiment, saying that I have to postpone further experiments because I have been called to join the army. This study was taken over further by Pavlov, who did a shunt between the portal vein and the IVC. And what was very important here was that something which the previous speaker has highlighted is that many of these dogs, when they were fed with meat, they developed signs of encephalopathy, which at that time was called as meat intoxication. And there was reversal of some of these encephalopathy symptoms with dairy products, because the dairy products possibly had very high amount of branched-chain amino acids. So this led to a concept that in cirrhotics, there is a decreased concentration of branched-chain amino acids, which increase in aromatic amino acid. This was the initial hypothesis of all the studies. So what it is that aromatic amino acids and branched-chain amino acid, they compete for the same receptor to cross the blood-brain barrier. And ultimately, the levels of aromatic amino acids increases in the brain, which leads to the accumulation of false neurotransmitters and inhibition of dopamine synthesis, and leads to neurodepression that is seen in encephalopathy. So this was the first paper way back in 1982, where they gave oral branched-chain amino acids to 7 patients to see if it is effective in liver patients with encephalopathy. There was no effect, but this was possibly the first study which told us that yes, absorption of oral branched-chain amino acids is possible. This was followed by another study, again published in the Gut in 1986, which had two arms. One arm received IV leucine. The other arm was randomized to oral lactulose versus branched-chain amino acids. This study was very interesting in that if we see this chart at the start of encephalopathy, the levels of phenylalanine and tyrosines were very high. And they gave branched-chain amino acid supplementation. And when there was a neurological recovery, all these levels came down. But on the 10th day, the phenylalanine and tyrosine levels were again at the same level as it was before treatment. But at this point, the patients did not have encephalopathy, while at this point they had encephalopathy. So there was something more than phenylalanine just or aromatic amino acids. So this was followed by two more studies. One was a branched-chain amino acids with placebo in encephalopathy, where they showed that there was definite improvement in the mental grade in the protein intake group with branched-chain amino acids. And then they supplemented it and compared branched-chain with zeaxanthin, and for 3 months, they showed that there was improvement in the portosystemic index. And in the patients who did not show such improvement, they again crossed them over to branched-chain amino acid group. And this study was basically a larger study than the previous study. It showed that branched-chain amino acid improved nitrogen balance better than other proteins. However, after this 1984 till around 2010, this 20 years, branched-chain amino acids suddenly disappeared. There were no more studies on branched-chain amino acids. There was possibly an evolution of knowledge. People thought that the original hypothesis which branched-chain amino acid came to the studies were wrong. So the new hypothesis that was believed is that in cirrhotic patients, the key to ammonia detoxification lies in the skeletal muscles. In a normal person, branched-chain amino acid supplies the carbon skeleton for alpha ketoglutarate to the skeletal muscles. And ammonia detoxification occurs mostly in the liver, and the skeletal muscle is a bystander, or it does a small amount of this. In patients with cirrhotic, there is increased ammonia in the systemic circulation, which leads to increased conversion of alpha ketoglutarate in the skeletal muscles. And it uses the branched-chain amino acid, and it cause lower levels. This was the basis of the resurgence of branched-chain amino acids, supported by some experimental studies where it was found that in rats, when ammonia causes decrease in the muscle and blood branched-chain amino acids. And people thought that external administration of branched-chain amino acid could help in increased clearance of ammonia by the muscles. And in fact, there are studies in animals which have shown that when cirrhotic animals, there is hypertrophy of the muscles and there is increased ammonia metabolism in the muscle. So how it works, basically, ammonia prevents the normal action of the branched-chain amino acids, and there is decreased protein synthesis with increased autophagy. And this is thought that if we can reactivate the mTOR receptors, we may possibly improve the protein synthesis. There are studies which have shown that supplementation of branched-chain amino acids pre and post treatment causes an improvement in the markers of proteolysis, that is phenylalanine, and the expression of the autophagy markers are decreased with supplementation. This led to 2 or 3 studies. I'm concentrating only on encephalopathy. So this was the initial study where they randomized patients to receive branched-chain amino acid and maldextron, and they compared the enteropathic measures and encephalopathy. This study was actually a negative study because the HE survival was not significantly different in the 2 groups. But what was different was possibly the number of days in encephalopathy was lower in the group that received branched-chain amino acids. There are other studies which happened like with very weak endpoints, like branched-chain amino acids were shown to improve the quality of life in terms of the hand grip strength and restoration of the normal energy. This was the meta-analysis which Dr. Madan has referred to. So this, I just like to add that this meta-analysis, the trial heterogeneity was quite moderate. There was no beneficial effect of IV branched-chain amino acid because 8 of these trials had oral and 7 had IV. And if you calculate from the study, the number needed to treat to prevent one recurrent encephalopathy is 5. So if I treat 5 patients, possibly one patient I can prevent from encephalopathy, which is not considered very poor, but it did not show any benefit in the mortality data or improvement of other parts of cirrhosis like albumin levels and the nitrogen balance. There is also a controversy on the amount of branch chain amino acids to be used. People feel that branch chain amino acids increases cerebral blood flow, and most of the hypotheses feel leucine is the main branch chain amino acid which helps. But there are studies which have been done now with only isoleucine, and they studied the brain areas to see the perfusion, and they found that at 1 month, neither leucine, neither isoleucine improved the cerebral perfusion. But at 8 and 12 months, there was a significant improvement with isoleucine. Though I know this is something controversial, this is against what majority of the studies saw in favor of leucine. Why isoleucine may be better is because if you see here, isoleucine has 2 points of entry in the TCA cycle. So possibly the amount of isoleucine may determine the effect of branch chain amino acids. But what I would like to say, we had a molecule called LOLA. So while LOLA failed, the branch chain amino acids may fail in encephalopathy for the same reason, because the end product of branch chain amino acid supplementation is glutamine, which is taken over again by body. And this is what we call the Trojan horse hypothesis. So this horse was used and the soldiers were inside the horse. Everybody knows about this story. So what happens is that once the glutamine comes out, this glutamine is reuptaken by the body, and possibly it will produce more of ammonia. So there's whether there is a role of a glutamine scavenger, like we combine it with a phenylacetate, which will be excreted in urine. But this again has its own share of controversy, because the moment I say excretion in urine and renal, most of these patients will be having a renal dysfunction with encephalopathy and cirrhotics. So branch chain amino acids may have a multiple mode of actions, but all of them is controversial. There has been articles where it says it prevents HCC developments. And the concept of this is interesting, but not convincing at this point of time. When I talk of encephalopathy, I don't only mean the patients in the ICU. We should remember there are patients with grade 1, grade 2 encephalopathy. So this is for all cirrhotics, that exercise is important. Both resistance and endurance exercise is important. There has been studies with growth hormone and testosterone replacement, and the results has been inconsistent. But basically, if we can improve the physical strength, there's possibly a lesser risk of decompensation. We also should keep in mind that many of these encephalopathy, because they are disoriented, they might fall down and break their bones. So the fracture prevalence anyway is very high, and the osteoporosis is in the tune of 35% in transplanted patients. So we should not forget, when you talk of nutritional supplements, about supplementations with calcium and vitamin D. And this is what is recommended by the EASL consensus guidelines. So to summarize, poor nutritional status is associated with more encephalopathy. We should consider adequate calories with sufficient protein intake. Protein restriction is not to be done in patients with encephalopathy. It's a myth which has been already addressed. Personalized nutritional therapy with periodic evaluation with both the caregiver and the patient, whether the diet chart that has been given is followed, whether it is suitable for this patient, has to be reassessed. Nothing is more injurious amongst all the food to the liver than alcohol. So practically, actually, nothing is restricted in a liver cirrhotic patients than alcohol, if alcohol is the cause. The muscle acts as the second liver in cirrhosis for ammonia detoxification and possibly has a role in prevention of encephalopathy. There's no definite proof. This is from the recent guideline, the ISHEN guideline, which says to say that animal proteins are bad, but definitely many of these patients may not tolerate animal protein. But branch chain amino acids are definitely more present in proteins of vegetable source. Nutrients like calcium, vitamin D, and zinc should not be missed, because many of these patients are deficient in these nutritional. And exercise and building of muscle mass under supervision is very important, because this will also lead to a better quality of life and post-transplant outcome in many of these patients also. I think that's it. Thank you so much for your patient hearing.
Thank you, Mithun, for very elegantly covering the molecular mechanisms